my vote. And now, without further ado, I am delighted to introduce the next speaker, Professor P Pandin from HUB Erasmus Hospital, the University Hospital of University Libre de Brussels, and he's expert in neuromonitoring process, and he's an expert in neuromonitoring, and he will talk about neuromonitoring and the regional cerebral oxygenation during thoracic surgery. Please take over.
Oh, thank you. Very good afternoon to everybody, to all the attendees. And I would like to thanks for the kind invitation. I'm working in Brussels in the same hospital than Laszlo, the previous speaker, and my talk will be dedicated to the brain function monitoring for thoracic surgery, which is a real subject, a real topic. And for that, this is my disclosures, mainly dedicated for BFM and POCUS, especially for neurosonology. Just some thought to our kind Ukrainian colleagues. And now I would like to start with this very recent recommendation published by the UK group, UK Society of Anesthesiology, led by Andrew Klein in Cambridge. And for the first time, they have considered to introduce the processed EEG and derived induces for essentially TIVA, but also for gases anesthesiology. And the recommendation based on this consideration about the processed EEG is to try to perform a BFM for everybody, at least as much as possible, and majority for major surgery, and to try to focus for the future, to try to personalize and terrorize the anesthesia patient to patient. About the interest of the brain function monitoring, for a long time, American Patient Safety Foundation has discredited the indexes, saying that the indexes was closed and blind technology. And for the future, it would be preferable to have an EEG or a quantitative EEG approach to be as much as possible to the physiological signal and the physiological situation of the different patient. And that is globally a very rapid definition of what could be the PEEG. Unfortunately, the PEEG was not really validated until just before the pandemic, as in this article of the PSF. Why not a standard of care? But we know that in the very recent publication in last February of the PSF 2022, we have now the recommendation to use PEEG, processed EEG, either for TIVA or for inhalated anesthesia, if you consider a MAC of a threshold of 0.7 MAC of your halogenated agent. And that is fundamental because owing to that, we could consider in the next future the PEEG of a real system to be introduced in our practice. Why use BFM? BFM is used to make the bridge for bridging the system, the system's neuroscience knowledge to the molecular pharmacology, what we are using and what we are making every day. And one of the major fundamental articles is the article of Merrill Brown in 2014, trying to define for the next future, and I think that we are in the next future, what could be the new tool for the new question in the different clinical conditions. And for that, it is clear that we need to have available, of course, a quantitative EEG or now processed EEG. Processed EEG mean that the machine is able to give you an information, an interpretation of the raw EEG. And secondarily, an element about the brain circulation, the brain superficial circulation, of course, the SCTO2 or the RCO2. And about that, we are considering these two modalities as additive. And so we are working and we are considering a B-modality or a dual modality for the next future for using in our patient for a better understanding of what happened during anesthesia in the brain of our patient. And for what? And it is for what? It is just for preserve the autoregulation relationship, and the preservation of the autoregulation relationship allow, of course, a brain function preservation. So to make that, to arrive to have good results, we have to consider first about the EEG. We have to consider further raw trace, the derivative values and measurements, and what is called the spectrogram, which is the relationship between the frequencies of the EEG and the power of each frequencies. And to try to develop the use of that, we have to work to develop holistic methods based on first trace pattern recognition and spectrogram pattern recognition. I will try to show you some example published in the literature, and of course, a multi-domain, multi-parameter analysis. But the two main elements is probably the trace pattern recognition and the spectrogram pattern recognition. The first experience published in 2011 from the Saint Louis group. And in this case, it has been well showed that when an anesthesiologist, a young anesthesiologist or experimented anesthesiologist has been trained to recognize trace during 2 hours only training program, these guys are able to predict the value of the BIS index depending of three main states: the sedation, the unresponsiveness state corresponding to anesthesia, and the deep anesthesia. And that is showed with a high level of sensibility, a high level of specificity. A second experience is very interesting, very more recent. George Mashour and his group has decided to try to use the second element, which is not a trace, but the spectrogram. And about the spectrogram pattern recognition, they have shown that it was possible using this algorithm to take decision to maintain, to decrease, or to increase the concentration of the medication. It was sevoflurane, but there is the same results about Tiva. And what it is interesting to see and to have as a result is that in black here, this is the control group without education about the pattern recognition, and the gray is the group corresponding to the group with education and intervention corresponding to the spectrogram recognition. And what it is clear, either in absolute value of MAC or relative value of the MAC, it is possible to decrease and to restrain the value of the MAC to have a less intensive effect of the drug on the brain for a probably better prevention of the postoperative delirium and at longer term postoperative neurocognitive dysfunction. I would like just to show you an example of the use of these famous patterns of the pattern of the spectrogram, and this is an old first example about a retrospective reading of spectrogram about EEG before CPB. And what is interesting is in this result, it was possible based on the pattern of the patients before the CPB, it was possible to predict the occurrence of, and based on the burst suppression level, it was possible to predict post-operative problem in this patient, but